IMR. And IMR is a really hot topic because this is all about microvascular obstruction, and we have a way of being able to measure microvascular obstruction as a point of care test in the cath lab. So no one could be better than Morton Kern, who's going to tell us more about IMR, coronary flow measurements, and how that may relate to STEMI outcomes.
Great. Thank you. So I was, thank you for inviting me to this luncheon symposium on a topic that I'm particularly attached to, but also to learn again about the coronary sinus. Thank you. And let me just back up one, two. Okay, so my job today is to talk to you about the diagnostic and prognostic role of IMR. Also, and just touch on potential for an angiographically derived method for measuring IMR. And then this is in the setting of STEMI outcomes, so it's confined to that area mostly. Now, my disclosures are here. These are companies that make physiologic measuring equipment. We've heard a lot about the microcirculation a little bit. I just wanted to put it again, repeat this graphic. I think it's very impressive that the microcirculation involves 90% of the heart. The epicardial circuit where we work mostly in is only 10% of the heart. The impact of what we do has to be translated into that microcirculation so the myocardium can recover. Missing that, we're missing the boat, and we probably have not had the right tools or the right methods to really get involved deeply in the microcirculation. My career started in coronary sinus thermodilution, as I was telling our sponsors, and I used to measure coronary sinus blood flow, and it was quite rudimentary with thermodilution, but it was informative and certainly different than the antegrade side of the arterial input circuit. So perhaps there's information on both sides. We're going to learn about microcirculatory resistance now. So the tools we have available in common practice are the epicardial measurements of either hyperemic pressure ratio across a stenosis, that would be the FFR, or the resting non-hyperemic pressure ratios, such as the IFR, DPR, RFR. And those are illustrated by the pressure tracings on the far left. In the middle is a technique of intracoronary Doppler wire measurement of antegrade flow down the vessel. You see the large diastolic component of flow and the small systolic components. We learned a lot about coronary flow physiology and so on. We also learned about coronary flow reserve, which is the sum effect on increasing flow from its basal state to its hyperemic state. Blood has to transit the epicardial artery, characterized by the pressure differences, and the microcirculatory difference, which is the change in the hyperemic flow when the vessel is in its state. But coronary flow reserve is not a very precise measurement of the microcirculation because it's impacted by the epicardial artery. So it's a two-component measurement. So unless you have a normal epicardial artery, whatever you're measuring in the CFR is going to be impacted by that stenosis. IMR normalizes for that epicardial stenosis by taking the hyperemic pressure difference, the delta P across that whatever disease is in the epicardial artery, by the transit arrival time, which is a thermodilution measure of flow. And below that, I'll show it to you again in just a moment, is the tracings that we get. We get both pressure from the pressure wire and temperature from the pressure wire. And by injecting saline, we can create the flow rates at rest. And then giving hyperemia, we create the flow rates at hyperemia. We compute both CFR and the ratio of pressures over the maximal flow gives you the index of microcirculatory resistance, a number supposedly independent of the stenosis. Here it is again at a little higher scale. You can see the technique there involves having a device, usually input into the core flow device to give you IMR with its calculations. You have to inject 3 cc boluses by hand 3 times, accept the results, inject, turn on the hyperemia, inject again 3 times. So it's a little involved, but not completely difficult. And the information is going to be highly valuable to study the microcirculation where we really need information that we haven't had before. I just want to remind you again, coronary flow reserve, independent of almost anything else, carries a prognostic value. That is, low CFR, people have events. They have heart failure, they have arrhythmias, they have they have obstruction, they may have infarction without obstructive coronary disease. Here's an old study from Dr. Van de Hoff. The curve at the top with the worst event rates, or the worst event rates, has a normal FFR and normal CFR. That's the green one. And then you have intermittently worse
outcomes as you add more negative factors. So the worst, obviously, is a positive FFR with an abnormal CFR. The best would be above, but CFR independent is what does it. Now, that CFR number lives in all of us, and it occurs across the board, and if you're unfortunate to have that, you're going to have events. But here is the IMR for patients who have STEMI. And so if your IMR is greater than 40 units, and this is by Bill Fearon, again, a decade ago, he demonstrated that your survival from death and MI is worse, and your survival overall global is worse when your index of microvascular resistance is elevated at 40. That was the number. Now, there may be a different threshold as we go on. It may be 25. Here's a quick clip from Dr. Ahn's paper talking about the combination of looking at both IMR and CFR, because these are not exactly the same thing. And microvascular obstruction is almost better predicted by some of the CMR data than it is by IMR alone. And there's interesting correlations here. If we look at the patient on the left, his IMR was 24. His coronary flow reserve was 2.2, with the normal threshold is around 2.5. His collateral flow index, showing perfusion from the epicardial system into occluded vessels, was 0.21. It's pretty low. And his recovery was 50%. CMR enhancement, meaning that was the area of injury. So 50%. Compare this to the patient on the right, who had a very high IMR of 56. Coronary flow reserve was almost 1, meaning not much is happening at all. This is occurring despite having a collateral flow index which is high at 0.37, and his CMR value was 100% enhanced, meaning he has a massive amount of impaired damaged myocardium and microvascular obstruction. You can imagine his outcome is going to be significantly different from the colleague, our patient on the left. Okay, the Oxfam study we heard about a little bit, or the OXAMI study. IMR predicts early complications. You can see the AUC curves. The best was IMR, followed by CFR. Less important were the angiographic scores of the PAMI and the Zwoli trials. That should be obvious. Better tools, better results. Again, the Oxford study confirmed what Dr. Fearon told us, that IMR was associated with early complications. Again, threshold of 40, the lower value having more complications. And if you combine IMR and CFR, you can have this spectrum of results, but the best outcomes are with normal, as you see on the bottom, and the worst outcomes are with abnormal, the positive numbers, and that's for death and MI. And in between, if you have CFR going one way and IMR going the other, you're going to have similar but less impressive results. Finally, what about microvascular obstruction, MVO? And this is in the presence of elevated microvascular resistance. And again, you have these three groups. No CMD at the top in red, microvascular obstruction, or abnormal index of microvascular resistance. That's your intermediate group. And if you have both that are abnormal or both together, you have the worst outcomes. This is short-term in the upper corner and long-term in the lower main panel. And again, if you divide them into further subgroups, you create this gradient. It's bad to have both elevated IMR and microvascular obstruction. There's just no way around it. Now, in the risk stratification schemes that we use, if you have no IMR impairment, that would be the right panel, and your MVO is absent, you're going to do pretty well and you can get standard of care. If you have MVO, regardless of IMR, or if you have both, you move into groups 2 and 3, and in these groups you need enhanced care. And these are the groups where I think the intermittent coronary sinus occlusion may provide the best answers. And of course, you have to study the groups that may have the biggest impact early. We have the tools. It looks like we have a new methodology or an old one brought back, and it's time to think about how we can make our patients better in the long run. So with that, I'm going to say thank you very much. Oh, I'm not. I'm going to say 2 seconds on angiographically derived IMR. There is a way to do this. Here's a paper that I pulled out. They take the same methodologies we use to compute FFR. They confine it to the diastolic period. They then do some computational fluid dynamics, and they produce an angiographic IMR without a wire. That's what I want. I'd like to have it, but I'm not sure it's here yet. Anyway, there is a fair correlation between wire-measured IMR and angiographic measured IMR. The AUC for IMR measured versus the derived was pretty good, as always it is in early preliminary studies, but I think this has got great potential. Okay, with that, I'm going to say thank you very much. The conclusion would be bad CFR, you're in trouble. High IMR, you're in trouble. We can use these tools to measure what we've done with PICOS. I'm going to say thank you again.